Okay, this is going to be a breathtaking COPD lecture for acute exacerbations when you're on the inpatient wards. So the most common presentation for a patient with an acute COPD exacerbation is shortness of breath. Now at the bottom there is a long differential for shortness of breath. These are usually shortness of breath episodes in patients with a long smoking history and often a previous diagnosis of COPD. They'll come in with dyspnea, cough, and change in sputum production is a big sign that this is an acute exacerbation. 80% of COPD users are previous smokers, so a heavy smoking history is suggestive of COPD. Other occupational exposures, though, and air pollution can cause similar lung disease. Most COPD exacerbations do have some trigger. We don't always figure out what it is, but that can be anything from pneumonia to an upper respiratory infection. PE is actually very prevalent in COPD patients on the inpatient side. GERD symptoms have been shown to be associated with COPD exacerbations. There's also some patients that just have them more frequently. And then bacterial colonization seems to be something that causes exacerbations, as antibiotics often seem to help. The differential includes things such as TB, interstitial lung disease. Alpha-1 antitrypsin deficiency is an important one to remember, only because everyone that has a diagnosis of COPD, guidelines actually recommend that they are screened for this at least once at the time of diagnosis, which is something that we often miss. Asthma is very similar. There's a lot of overlap between asthma and COPD. Obesity, hypoventilation syndrome, or Pickwickian syndrome is shortness of breath in just very obese patients. And then, of course, pneumothorax and lung cancer are things you would not want to miss. On physical exam, patients will have an increased AP diameter, such as barrel chest, in some patients with end-stage emphysema. You might also hear diminished breath sounds. You might have expiratory phase prolongation, polyphonic wheeze, meaning wheezing with lots of noises, accessory muscle use, some clubbing from chronic cyanosis in the nails. You should also look for hepatomegaly, jugular venous distension, and other signs of right heart failure in patients with really bad COPD leading to pulmonary hypertension. And in patients with really bad obstruction that are having acute hypercapnia, a lot of times they'll present with a headache or altered mental status. These are red flagged symptoms in a COPD exacerbation. This is someone that needs to be put on ventilatory support and is trending towards not doing well. At the bottom is a link, but you can also just Google the Stanford 25 COPD. It goes over a lot of the stigmata or other presentations to look for on a physical exam with the patient with COPD. There's a lot of different labs and diagnostic tools that we can use, although the history is probably really the best for COPD acute exacerbation. One of the things is looking at a blood gas, an ABG or a VBG, and the major thing you're looking for is hypercapnia or elevated CO2. A couple blots down on the table. Also a BMP, looking at the bicarb can actually help determine if a patient is hypercapnic. Is this an acute hypercapnia, something that is a little more worrisome? Or is this a chronic hypercapnia? Is the patient having such bad COPD that they just live with a high PaCO2? If that's the case, a little less worrisome acutely, although a sign of pretty bad disease. A CBC may show chronic polycythemia or an elevated hemoglobin. This is again because of chronic cyanosis in patients that have trouble oxygenating. A chest X-ray can show a flat diaphragm, hyperinflation, which is usually more than 10 posterior ribs on the imaging. And again, this increased AP diameter that you'll see on the lateral X-ray. A lot of times you just need to see a lot of normal lateral chest X-rays to then see, oh, this one looks bigger, this one looks more barrel-chested. This is increased AP diameter. A CT is not indicated for someone who's coming in just for an acute exacerbation unless you're looking for a PE or something. But a lot of times you will see emphysematous changes, which I'll have a picture of. Other things that we often do, things like sputum culture, urine strep, and Legionella. Not a lot of evidence behind these, but this is a way to check for other bacterial colonization that might be need to be covered by antibiotics. And then also considering an echo or pro-BNP during the admission if you think that the patient might have congestive heart failure and that this is shortness of breath from a heart failure exacerbation. This is also a good way to kind of further investigate if there's signs of pulmonary hypertension or right heart strain. And then finally, chart reviewing. Chart review for all these patients. See if they have old pulmonary function tests. See if they have old COPD exacerbations, old echoes, if they have the A1 alpha trypsin deficiency screening. These are all things that need to be known on a COPD patient. So this is a typical chest x-ray for a patient with COPD. You can notice hyperinflation where they have tin ribs or more visible. Also some flattened diaphragms without the humps that you would usually expect. This is a CT of a patient in very late stage emphysema. These are huge bolus emphysematous changes. These are pretty impressive, but they're worth highlighting that you will be looking for smaller ones just to see if other patients have emphysematous changes on CT if you're going through the imaging. Pulmonary function tests we'll talk a little bit about, but the brief summary is the first thing to look for is trying to determine if this is a restrictive lung disease or an obstructive lung disease. With restrictive lung disease, as you remember, you'll have a decrease in the FEV1, which is the forced vital capacity in the first second, and a decrease in the forced vital capacity total, which will make the ratio about the same. In restrictive lung disease, you'll also usually be associated with decreased total lung capacity. Meanwhile, obstructive lung disease will have a decrease in FEV1, but a normal FVC, which will bring the ratio down. This is typically the case. In patients with obstructive lung disease, there are two major classifications of COPD, or chronic obstructive lung disease. This is chronic bronchitis and emphysema. One of the ways to tell the two apart is looking at the diffusion capacity, or the DLCO. In emphysema, it is decreased. In chronic bronchitis, it stays pretty constant, and we'll talk a little bit about why in the next slide. This is an example of a PFT that will be visible in chart review. First is looking at the basic spirometry. We see that the FEV1 is down, the FVC is down, the ratio is down. This is all consistent with obstructive lung disease. You'll then see the DLCO is also low. This is consistent with emphysema. And the total lung capacity is normal, which is a good way just to confirm that this is not a restrictive lung disease. The major difference between chronic bronchitis and emphysema is the pathophysiology. These are both under the category of COPD, but chronic bronchitis is seen as having heavy inflammation and excess mucus in the bronchus, as you can see in the image, whereas emphysema has breakdown more microscopically at the alveolar membranes. With the membrane breakdown, that is why there is difficulty with diffusion across the alveolar membrane, which is why emphysema is associated with a decreased diffusion, a decreased DLCO. The inpatient treatment regimen for COPD is actually pretty straightforward. A couple of things. First, you want to have the target O2 usually between 88 and 92%. These COPD patients will often have baseline low oxygen levels, but you don't want to have oxygen sats too high. The major reason is this theoretical Haldane effect, where higher oxygen sats will actually displace carbon dioxide from the hemoglobin and can worsen hypercapnia, which is one of the biggest things you're worried about in an obstructive lung disease, is the hypercapnia and less so much the mild hypoxia. So we put them on oxygen if they're less than goal sats of 88%. We'll treat them with bronchodilators, usually albuterol or a duoneb, which is just albuterol and ipratropium, muscarinic agonist. We do that at Q4 or Q2 if they're really needing it. Steroids are given, 40 milligrams PO for 5 days. Some notes about the steroids. Oral is as effective as IV. 5 days is as effective as 14 days from the REDUCE trial. So 40 milligrams, 5 days. Antibiotics, there's a couple different antibiotics you can use. Here at our institution, we often just go with azithromycin for 5 days, plus any pneumonia coverage that is indicated if a patient has a lobar pneumonia or needs to be treated for inpatient pneumonia. If they're on azithromycin daily coming into the hospital, you would want to try a different antibiotic on top of their daily azithromycin. And additionally, you can use other antibiotics for COPD exacerbation, so something like doxycycline or Bactrim or even amoxicillin, but usually we stick with the azithromycin. And then finally, if the patient is getting worsening respiratory status, if they have an acute respiratory acidosis, if they are really looking like they're getting tired, they're tachypnic, they are using a lot of energy just to breathe, BiPAP positive ventilation is what is indicated to help blow off the CO2. BiPAP is what is needed to help address the hypercapnia. One note on home inhaled medications, if they are getting ipratropium, you could hold any muscarinic agonist they are receiving, but a lot of times we will just keep them on. It's a good way to remind the patient that these are daily controller medications that they need to be taking on the regular basis. We'll talk a little bit about COPD staging. Basically, it is based on objective lung function and symptoms. The objective lung function is based on the pulmonary function tests. There are 4 stages of COPD severity. They are based on the FEV1 range, as you can see on the far right. If they are greater than 80%, that's considered normal. 50 to 80%, grade 2. 30 to 50%, grade 3. Less than 30%, or less than 50% with actual respiratory failure, these are stage 4 or very severe COPD. One of the symptom scores is called the Modified MRC Dyspnea score. It's a grade of 0 to grade 4, totally just based on when you have dyspneic symptoms, what level of exertion requires you to get short of breath, as indicated in the chart. Once you know the risk classification based on the PFT scores on the left and the MRC symptom score at the bottom, you can then use the COPD staging assessment tool, which is in the 2017 GOLD guidelines, to determine if the patient is in COPD stage A, B, C, or D. The exacerbation history on the right in the column can also help determine the risk. You can also use, they have the CAT list at the bottom. That's the COPD assessment tool. I haven't seen that used as much. I put an appended slide in there. But this is how you would grade COPD patients, and you can, or stage COPD patients. And this can play a role in the outpatient treatment, although not really significantly. So after we've been treating the patient, pretty straightforward, with bronchodilators, with antibiotics, steroids, and oxygen support if they need it, we need a plan for dispo planning. Do they need home oxygen? Do they need changes to their outpatient treatment regimen? Smoking cessation is important. Education on inhaler use technique, making sure they're using it, is important. Making sure they're up to date on all the vaccinations. Making sure that if they are in stage 3 or stage 4 of the COPD things, that pulmonary rehab is recommended, which can help improve lung function. And then for a lot of these patients, they will fall into the lung cancer screening diagnosis. So if they have not gotten a CT yet, it might actually be indicated just to rule out lung cancer. Of note, there is a score called the Bodie score, which is based on PFTs, 6-minute qualt test, the MRC symptom score, and BMI. And this can help predict mortality, which is in the bottom right table. The actual calculator is in the appendix of this presentation. Outpatient treatments are good to just be aware of, because these patients will come in on outpatient treatment and need to be determined what outpatient treatments they should be sent out on. New standards are recommending treatments based on the stage A, B, C, or D, but really it's a pretty straightforward, safe bet to do an escalation in therapy per this chart. So first is just a bronchodilator, a short-acting beta agonist as needed, like albuterol. Next is a long-acting muscarinic antagonist. This is something like tiotropium, or what's known as Spiriva. If that's not controlling the symptoms, if they're having exacerbations, you can add on a long-acting beta agonist and do a combination therapy. And finally, if that's not working, you should do what's called triple therapy, which is either a LAMA, LABA, and inhaled corticosteroid, or your LAMA, like a Spiriva, added on to a beta agonist inhaled corticosteroid combination. That is actually the most common, something like Spiriva and Advair. The triple therapy, this Trelegy, is only recently FDA approved, and even the LAMA-LABA combination therapy is relatively new. If you are on rounds and want to sound particularly pretentious, you can use the relevant trial column here to reference important pulmonology landmark trials that are what these recommendations are based on. If you are still having issues, if the patient is still not doing well, they can also add a medication called roflumilast. And there's a Lancet article that discusses this. They can also be on daily azithromycin, which a Cochrane review shows decreases exacerbations. And then oxygen if their respiratory O2 sats are less than 88%. Of note, a lot of these medicines will decrease exacerbations or hospitalizations. The only COPD medications to improve mortality are long-term oxygen therapy and smoking cessation. These other medicines really just help keep people out of the hospital, improve quality of life, but there is not data supporting them decreasing mortality. If you have any feedback about this lecture or others, please shoot me an email at jberk7@jhmi.edu. If there was information that was confusing, if there was something that was missaid, if you have extra questions on how to manage these patients on the wards and how you think a subbite can be better prepared for these wards, please let me know. For other reading, there's the COPD pocket guide from the GOLD organization. There is a reading list from the American Thoracic Society. There is a great online resource called COPD Made Easy at epomedicine.com with the link there that is worth checking out. And there is a good article on interpreting PFTs from the AAFP. There's a couple extra appendix slides that you can also check out. Thanks so much.